Dear urologist Preeti from Pure Urology, welcome all of you. Today topic is again not surgical related, technique related, but yes, more important than that. As you all know, last 2 decades, extensive investigations have come to detect the suspicious lesions in the prostate for after the PSA is done. One among them is mpMRI, but it is more costly, and usually surgeon will not involve directly. It will be guided by PI-RADS score by the radiologist to the urologist. But ultrasound traditionally has been there for the diagnosis of the suspicious lesions, size of the prostate, post-void residual urine, and per rectal. It is replacing the finger before you do anything. Certain urologists do ultrasound on regular basis in the OPD, whether the patient has carcinoma of prostate or not. Now in the ultrasound, latest things have developed where you will see with high frequency ultrasound, because it is superficial, just because the rectal mucosa, if you have any very high suspicious lesion, if you are intelligent enough to pick up those lesions, it will help in the diagnosis of the patient. So based on that, today our speaker is Dr. Mahesh Desai, sir. All the world knows, not India, all the world knows about Dr. Mahesh Desai, sir. But youngsters will be coming. They also will be interested to know how one person can do so much in urology. For them, I am reading a little bit of patiently is the CV. The today topic is otherwise micro-ultrasound in prostate cancer diagnosis. Micro in the sense high frequency to detect lesions. Dr. Mahesh Desai sir is MS, FRCS, FRCS London, FRCS Edinburgh, and FACS. Consultant urologist and managing trustee, Multibai Patel Urology Hospital, Dr. Virendra Desai Road, Nadiad, Gujarat, India. His honors and awards are, it's a big list, but still it is worth revising once his achievements, so that for all the youngsters, they may get enthusiasm to work hard. UNVS International Award of Urology, late Dr. Piyush V. Patel Award, Ahmedabad Medical Association, St. Paul's Medical British Association of Urological Surgeons, American Urological Association President Citation, Quimpro Platinum Statement Award in Healthcare, Richard Taft Visiting Professor, Guy's Hospital, UK, Fellowship of American College of Surgeons, Lifetime Achievement Award, Endourology Society, Bangladesh Urology Association Gold Medal, SIU Felix Gain Medal, Indian American Urology Association President Medal, ranked top 10 best doctors in the world for stone management. MPH has ranked as top 10 best hospital in the world for stone management by experts, CAPES leaders in kidney calculi. Awarded White Coat Awards for Medical Pioneers by Times of India, Gujarat Healthcare Leadership Awards 2020, CME Excellence Dronacharya Award for Exemplary Contribution in Urology 2021. Personally, I want to share my 1 minute in this before handovering the program. Like any other urologist I introduced, in 2005, when I started private practice, I was not well versed with PCNL, RIRS, and laparoscopy. Naturally, whatever you learn in your PG program may not be sufficient to the present standards. So in 2007, first I went to Nadiad, and that time RIRS was demonstrated by Dr. Mahesh Desai sir, Dr. Oliver Traxler sir, and even Michael Grasso sir in 2007. Then I got motivated and I decided in Ahmedabad airport that I will buy equipment which was 30 lakhs at that time, including the laser mission. After that, I focused. I went every 6 months to Nadiad. To my memory, 2007 to 2015, Dr. Mahesh Desai sir has almost done every 6 months one CME, which was rupees 2,000 to 2,500 rupees, including the CD of the previous workshop. And if it's hands-on on the animal models only, it was costly. It was around 7,000-8,000. I used to think that I only laparoscopy nephrectomy on pig I have done. That is costly per se, because we have to arrange all the animal model. With that, then I used to go for the laparoscopy suturing. They have a modules. So personally, I learned laparoscopy and RIRS because PJ it was not there at that time. Then later on, I became consultant, and to the extent in the same Nadiad hospital, sir has given me in 2017, first time allowing me to do live surgery RIRS from mpUH. So this is what I wanted to say, that teaching and learning is not only thing, encouraging the juniors to come to that stage is also important. With this, my words, I pronounce sir. Happy that in pure urology, we are learning still from him new things. Recently, he presented this micro-ultrasound in one of the conference in Bangalore. So I was watching online. He has given 3 clinical scenarios, how it helped. Then I requested, sir, can you please present in pure urology? With this introduction, I will hand over the program to Mahesh Desai, sir. Thank you very much, sir. Please.
Thank you, Chandramohan, for your kind words and inviting me to this popular pure urology video series to share my experience on ultrasound, which is new one, micro ultrasound. And let me share my thing. What you are doing is a very good teaching the people and sharing the knowledge. That is good. Can you see my slides?
Yes, yes, sir. Very clear, sir. First slide.
Okay. So thank you again very much. And I'm very passionate about ultrasound. So if I overshoot the time, please let me know.
No problem, sir.
In recent year, can we reduce this? In recent micro-ultrasound technology has transformed our approach to detecting and managing prostate cancer, offering unprecedented clarity and precision in imaging. Today, we delve into the capabilities, advantages, and future potential of micro-ultrasound as we navigate its role in improving patient outcome and reshaping the clinical practice. Today, we explore this cutting-edge tool and its profound impact on the field of oncology. Prostate cancer. The Patrick Walsh said in 1995, 70-year-old male with a metastatic prostate was once 50-year man with a localized curable disease. The prostate cancer is a major health problem in male population. Estimated 1.4 million new cases and 37,500 deaths worldwide. Second most common cancer, ranked 5th among the cancer death in 2020. It was till we developed the trust, it was still dependent upon the digital rectal examination, biopsy, or TURP biopsy shows 5-10% cancer, and only treatment available that time was orchidectomy and stilbestrol. But the trust brought the new dimension. Ability to feel and visualize the prostate by the same urologist offers a previously unequal opportunity for diagnostic acumen. And the PSA came in 1988 by Professor Stamey from Stanford. And that was a PSA is a game changer. PSA is not cancer specific, it is a prostate specific, but it was a tumor marker. 1 in 50 with a PSA level below 4 nm per ml, 1 in 3 for PSA of more than 4 nl per ml or greater. And as PSA increases, chances of cancer increases. The transrectal sonography, I feel the gray scale which I was using till now was a better predictor of the volume. Reproduces, that time you were looking at the BPH volume, reproduces McNeil zonal anatomy and visualizes the hard nodule, its volume, its location and staging, and you can do the biopsy. That time, the Sinora described the trust characteristic of the cancer, and he found 67% were hypoechoic, 32% were isoechoic, and 1% was hyperechoic. If that thing was palpable cancer, then 82% had a hypoechoic lesion on the ultrasound. If it is a non-palpable, 35% had hypoechoic. If the tumor size is less than 1 centimeter, only 19% were visualized. And the only thing which allowed us to do by transrectal sonography was a biopsy. And then we did a systemic prostatic biopsy, 12 to 18, depending upon the size. If size is bigger, the pickup rate was little low, but by size was small, we could pick it up much more. And in India, usually the majority time the size is little small. The patient with a positive biopsy had a significantly small prostate. But if you want to pick up more, you started doing the extended biopsy. And the way we did extended biopsy, we started picking up the more cases, more positive cases. But then to increase the sensitivity of 18 to 55% on a gray scale, we included something like elastography, contrast enhanced ultrasonography, color Doppler to detect vascularity, or a contrast enhanced ultrasound, and then histoscan. That helped us. But still, there was a lots of high inter-observer variability. And then DRE, PSA, and a trust combination, systematically sparing biopsy sample, yielding 48% positive for clinically significant prostate cancer. Risk of underdiagnosis was there. Delay in appropriate treatment was there. Risk of prostatic mortality was there. Unnecessary risk of repeat biopsy if the PSA start increasing. Then came the mpMRI, and this multiparametric MRI found to be the solution to this problem. It was a game changer and represents a clear improvement over the systemic biopsy. Still, mpMRI targeted biopsy still misses small, high-grade cancer up to 20% of Gleason grade 2 cancer. But most important contribution of MRI was the prostate imaging reporting and data setting, PI-RADS. For multi-parametric MRI, it has been created, validated, and improved. And PI-RADS has made a game changer. And then you could localize, you can take biopsy, and you can do, and it's very, very reliable, you know. And you have a PI-RADS 1 and 2, where the signal intensity on ADC is low. Also on the PI-RADS 1, in PI-RADS 1, even DWI has a low signal intensity. As PI-RADS increases, the PI-RADS 2, it is a diffuse increase in the signal intensity on DWI with a low ADC. And here is a picture. But again, MRI is not our cup of tea, where we can't read it as radiologists read it. We have to depend upon their judgment. So PI-RADS 1 and 2 does not require any biopsy. While PI-RADS 3 is intermediate appearance, not in categories of 1 and 2 or 4 and 5. And here there may be an overlap of some inflammation or some instrumentation where you can have edema and then you can have a problem. Again, this doesn't require a biopsy. But PI-RADS 4 and PI-RADS 5 is different. Here, the focal area of reduced ADC but ISO intense signal intensity on DWI. And similarly, here you can see that it is very, very clearly seen as an increased intensity. Here is a lower, but it's a clear cut. While here you can see that the irregularity and a large one. This is a PI-RADS 5. And here you require a biopsy. Problem was in transitional zone. And again, MRI helped in detecting tumor in PI-RADS, it is 1, 2 doesn't require, but PI-RADS 3 doesn't require, but PI-RADS 4 and 5 in transitional zone, you can do a biopsy and you can diagnose the thing. So that was the most important. But there were limitations of mpMRI. The impaired renal function, his replacement, pacemaker, you can't do MRI. And then usually those are the people are old people, and there where the prostate cancer is common. But mpMRI for a prostate cancer here to stay, but supplementary tools are also needed. Again, what additional thing came is a fusion biopsy on mpMRI and MRI and ultrasound, where you match the contour and then you take the transperineal biopsy, especially on the anterior part of the prostate, and you can get a bigger yield. What was the aim at that time is to increase the positive predictive value of biopsy. Direction with localization, it was the responsibility lies with the urologist. Sampling, responsibility lies with the urologist. Interpretation, responsibility lies with the pathologist. Ultimate paradigm shift would be the accurate localization and a quantification of cancer. And that's where the high resolution of micro-ultrasound came in the picture. And then this is a better image, better patient care, reduces the false negative, faster detection of suspicious area, real-time targeting of suspicious area possible, track the suspicious region over time. That means you can do the active surveillance on micro ultrasound resolution equal to MRI, much better ultrasound system, urologist control and performed in a single visit in office only. First, it was detected in 2014. It was a 21 megahertz micro ultrasound, and that was done by the Exact Imaging in Toronto in Canada. But in 2019, 29 megahertz system was developed. But along with so many investigation, prostate risk identification using a micro ultrasound, which is known as a PRI-MUS, equivalent to the PI-RADS. A PRI-MUS was equivalent to PI-RADS was established. With combination of high frequency ultrasound waves of 29 megahertz and a very high crystal density, a spatial resolution of 17 microns compared with around 300 microns on a conventional truss achieved. A physiological glandular duct and acini of the prostate have a diameter of 150 to 300 microns. Therefore, the histological architect of the prostate can be visualized by this modality. And here is the physics of micro ultrasound comparing 9 megahertz to 29 megahertz with the frequency and the crystal spacing. And that was the most important. This is the machine which I purchased about 4 or 5 months back. And the most important, if you see the transducer, it is a long transducer with an oblique surface. And this whole thing comes in the picture in contact with prostate. And then you can visualize prostate from apex to the base. And it is like a B mode. It is completely comes down and completely come down, not like a sector where you have like a grayscale where you have to do on both the direction. But here the ability is to visualize the whole thing, and you can increase to 60 millimeter. So a small prostate can be increased, or even large prostate can be seen. High frequency enables extraordinary resolution that lets you see more anatomical detail and tissue differentiation. Like capsule, you can see all over the place, the seminal vesicle, ejector duct, peripheral zone, urethra, you can see, transitional zone you can see, and then any pathology you can see like hypoechoic area, hyperechoic area, or it is a heterogeneous area you can differentiate. So tissue differentiation can be appreciated on a micro ultrasound. And here ability to visualize the margin of the prostate and peripheral zone in great detail, textural changes in tissue associated with the disease process. Ability, this is very important, ability to visualize full depth of most prostate up to 60 millimeter. And that is most important. You can decrease and then you can increase the peripheral zone so large, like a whole peripheral zone, see like a tissue, you can visualize it. And of course, when we bought the machine, the Andrew Lewis came from Switzerland to teach us. Though we were familiar with the ultrasound, but he taught us many important function of the ultrasound, like measurement of the prostate and how to take a biopsy. And this is a biopsy. Same probe can be used for a transrectal sonography. And then with attachment, you can use from a transperineal biopsy. And here transperineal biopsy is taken where anterior part of the tumor can be taken very nicely. As you know, majority of the prostate cancer lies above the anterior to the midline. So this is very good. And that is also in a anterior horn. So this is very important. Now here you can do the fusion of the MRI and micro ultrasound, what is known as the cognitive imaging. It's not like contour matching. It is a cognitive imaging, which you learn. It is not very difficult. And you can see here the suspicious area which MRI, the radiologist has marked, and you can detect that, and you can take the precise biopsy. And that was a very important. And then I'm familiar with the transrectal, and I do the transrectal all the time. And there is the transrectal attachment. And here what you do, the whole prostate is pushed. When you push it, the prostate gets squeezed, and when you take a biopsy, you get a more tissue. That is the biggest advantage. And plus, then if you want to do an anterior horn or a lateral biopsy, you first raise the prostate, then rotate the probe so they can visualize the anterior horn or a lateral part. And then if you want to take near the apex, you slowly withdraw, and then the biopsy line will come. And then you can take that thing. So here you have taken the anteriorly, and you have taken, this is the biopsy needle. And then if you can see you can leave the track here. The biopsy track is seen, and you know when you go next time, you can make out you have taken a biopsy from here. So for example, this is a tumor, and you want to do a focal therapy, then you know where you have taken a biopsy, and you can treat that area if you want to do it in the future. That is not yet started, but this is how it is. So I feel the transrectal and transperineal biopsy with the same probe and software gives exceptional detection rate with and without use of MRI. So here is I was getting used to the machine. He was helping him. First, you introduce the probe parallel to the spine, and then you bring it close to the prostate, and you can see the capsule. You can, if you want to take a biopsy, put a needle between the seminal vesicle and the prostate, that angle, and then you inject xylocaine. And then whatever suspicious area you want to take a biopsy, you can take a biopsy. This is, I'm giving the block on the left as well as on the right side. And here is a angle between the seminal vesicle and the base of the prostate. And the needle exactly goes there. You can see the needle. And then you inject xylocaine locally so that the nerve of the prostate is blocked. And then you can go ahead and then take a biopsy. This is the hypoechoic area. I want to take it. I may take 2-3 biopsy from there. So I exactly have a biopsy guide and then the biopsy gun. And then I bring it, and here is the biopsy taken. So you have a very precision biopsy, and the image is so magnified that you take proper targeted biopsy of that. So like PI-RADS, this is a PRI-MUS classification of the lesion in the prostate. This is a PRI-MUS 1 interductal architect. This 2, 3, 4, 5. 4, 5 is malignant. This is low malignant, or this is no malignant. This is the intermediate. You have to find out whether you do it. Let me give you some example. This is the PRI-MUS 1. And you can see now this dilated thing are ducts. Whenever you see a large number of ducts, is benign. Whenever you don't, this is the part of the probably BPH, but no, this is a whole gland is the interductal. It's like a Swiss cheese appearance. Then PRI-MUS 2, where you see hyperechoic area with or without, but ductal patches you can see. You can see all ductal, dilated ductal. And this is PRI-MUS 2 is a non-malignant. Sometimes you have some inflammation, that's why you have this thing. Now this is the PRI-MUS 2, again, hyperechoic with or without ductal patches. And you can see the ducts. You can see the ducts all over and here. And this is again a PRI-MUS 2. This is PRI-MUS 3, where a mild heterogeneity and a bright echoes in a hyperechoic. Now you can see the heterogeneity. Hypoechoic, less hypoechoic, little hyperechoic, rear hyperechoic. But then ductal, you can see the ducts all over the places. So you may judge whether you want to take a biopsy. If you are in doubt, and you can take a biopsy. If you feel confident, you can double check it again after a couple of months. And then this is a PRI-MUS 3. But what is most important is PRI-MUS 4. And this is a starry sky. And this is 100% malignant. And this is either 3+4 or 4+4. But this is starry sky. And here you see a hypoechoic area, very small hypoechoic area. And you can see very well defined. And then remaining is all benign. So this is a PRI-MUS 4. And this, of course, needs a biopsy. And here you see the white patches all over the white patches. This is known as a cauliflower. This is PRI-MUS 4. This is a cauliflower pattern. Why cauliflower? Because it looks like a cauliflower. And then, the white patches with patches all around, it is the PRI-MUS 4. And you can do the biopsy. Now, PRI-MUS 5 is irregular shadowing or a mixed echo lesion or irregular posterior border. You can't, posterior border is not, it is hypoechoic here, and then it's not seen here. So the whole gland is showing this is the primus 5. And in the primus 5, you see hypoechoic area with shadowing. These are the shadows which is coming down. It's like a shadowing in the hyperechoic area. So here you can see that this is primus 4, and this needs a biopsy. Now, most important is the anterior zone, where you can have the malignancy, the focal anterior tissue. Now, here is a BPH, and this is a peripheral zone anteriorly, and you see a hypoechoic area. Usually in the anterior zone, it is the oval, and tear shape. And then you can see that capsule was seen up to here, then it is not seen here. So this is the area. Then again, this is a anterior zone, anterior horn, and he can see the tissue, which is a hyperechoic, but you don't see any tubules there. And then this is so this is a hypoechoic finger-like projection, storm cloud. This is a storm cloud lesion occupying the anterior horn and lateral prostate. So here, anterior, to detect the anterior cancer is very, very important. Most important, again, I come back to the transitional zone. It is very, very difficult to do it. This is a MRI where there is a malignancy. But this is a micro-ultrasound. You can see transitional zone. It's a hypoechoic area with shadowing. And here, margin is not seen. It is going down. This is a cancer. But here, a normal transitional zone. This is the normal transitional zone. This is the nodule. This is the capsule between the transitional zone and peripheral zone. Is very well defined. And then if a small patches like this, you can see is dilated tubules, and that dilated tubule means there is no malignancy there, and this is all BPH. Here you can see the adenoma. Adenoma is very clearly seen, and that the mixed echogeny, but still you can see lots of tubules inside, and that's a benign gland. Here is again normal benign tissue. Here you can see the capsule very. So when you see the capsule very well, it is no, malignancy is not advanced. Now here you see the BPH, which is a hypoechoic area, and this is a capsule is not seen. This is a tissue. There's a shadowing going out, infiltration into a peripheral zone, and same thing here. And you can see that same picture. A hypoechoic area with infiltration outside, and this is where the capsule is broken, and this is a malignancy. This is another hypoechoic area. Here the capsule is very well seen, but anteriorly it is not seen here. It is a hypoechoic. Here, and you see the hypoechoic area. So on this part, you can see it, and again there are different nodule here. You can see that this is the nodule, and then this is the two nodules are there. So here again, hypoechoic area, and this nodule, and this is suggestive of malignancy in the transitional zone. And again here the capsule is broken, and between the transitional zone and peripheral zone, and then this is a malignancy, pakka malignancy, and you have to take a biopsy from there. This is the infiltration into peripheral zone. Now, of course, similarly, this is very well defined, as well as outside capsule is very well defined, where you can then do it. This is another case where you can see the hypoechoic area with now this is the tumor here in the apex, and then this is the tumor, which is infiltrating into the transitional zone. And that's malignancy. So anterior prostate cancer with a micro-ultrasound. Again, you can see that the peripheral zone, which is quite normal, This is all tubules, and this is the low risk. This is a primus 3, maybe some inflammation, but this is all cheese appearance, tubules are seen. And now sometimes this may be a little small area. But what you are aiming at, detecting a small area, and that may be the thing, and you may suspect and do that. This is the primus 4. You can see that whole area, hypoechoic, it is going down. And you get a video film, and you can go on seeing 2, 3, 4 times before you realize that this is a tumor. This is a tumor. This is a tumor. This is a primus 4. This is another hypoechoic area. and this is in anterior part of the prostate, and this is the sphincter, and then here you can see that. So it gives you a very good, this again, here is a little doubtful. You do see a BPH, but there was we've taken a biopsy. You can see that I have done a transrectal biopsy to the anterior zone. There was a hypoechoic area, but there was a little shadow here. And then exactly biopsy, we'll see it is gone through the hypoechoic area. And it turned out to be a hypoechoic between the two nodules. These are two nodules, and that gives an artifact. And this is the artifact. And that was a hypoechoic. I took a biopsy, and that turned out to be a benign. And this is again hypoechoic here, and a little bit on the peripheral zone, which is infiltrated. You can see that. And then it was a PRI-MUS 4, high risk is a PRI-MUS 4. Now, let me go on the cases, which now this is important. This is important because I'm not looking at 70-year-old man. This is 55-year-old male with PSA 3.3. He won't do anything. But then he had a small lesion here. I saw, and then I thought it was a PRI-MUS 4 lesion. Again, you can see that it is a lesion in a different angle. This is a PRI-MUS 4. So I wanted to confirm. So I did an MRI. And MRI confirmed there was a small nodule there. So what I did was, this is the lesion. So I did a MRI, cognitive fusion, and then a biopsy. What it turned out to be Gleason pattern 3, and 50% of the core was a positive. Second biopsy. Because when you see like this, you must take 3 or 4 biopsy. And here the biopsy was done, and it was a Gleason 3, 30% core, probably peripheral. And this was one more biopsy, and then Gleason 3, and it is 80% core. And this is the 4th biopsy. And because he was a young man, so I did the 80% core and Gleason 3 biopsy. So here all were targeted biopsy, no systemic biopsy. So only 4 biopsy. And then it all were positive, and it was a 3+3. And then I decided I will do nerve sparing radical prostatectomy. And then I did it, and I found the same lesion. Same lesion. Now, you might think, Chandra Mohan, this is an overkill. Such a small lesion. 50,
suspecting only on such an hypoechoic small lesion in 3.5 PSA, highly beneficial to the patient if he is less aged. Especially
people,
with only 4 biopsy pieces. That too, only 4 biopsy pieces taken.
Now in America, when they did with the PSA, they found this thing, and then they kept it on surveillance rather than operating on them. But then I found, we did another epidemiological study in Naryad, where we found that our prostate was very small, especially in farming village. In a small town where there's the diabetes, obesity is there, prostate may be a little bigger. But then the McNeil said that the prostate cancer start from the 3 mm from the capsule, and doubling time is 2 years. Now this patient has got this tumor. In 2 years' time, there is a good chance that it might penetrate the capsule and go out. Then I will lose. So that time it become a metastatic. So 70-year-old male with a metastasis cancer, once he was 50 years with an organ confined. So this is 53 years old, organ confined. So I did a radical prostate, and it's a Gleason 3. My aim was to detect. Now I may be doing radical prostate now, but tomorrow I might do a nano knife or a HIFU later on. This is a second 60-year-old male with a raised PSA since 2019, and a left apical region. His prostate cancer in father took hormonal therapy and increased PSA in brother. So he got a strong family history, and his PSA was going up. And I did first a grayscale ultrasound, and I found that the anterior there was a tumor. And there was a small tumor in the peripheral zone in the posterior in the posterior part. And here is a tumor. So I did an MRI. An MRI, I found a PRI-4 nodule on the top, and then PRI-3 scattered in the bilateral peripheral zone. So I did that time I got a micro-ultrasound. I did a micro-ultrasound guided biopsy, and this was a hypoechoic area. And this was a Gleason 3, volume 14 mm, means 70% core. And this is again another biopsy taken, 100% core, Gleason 3. And look at the thickness of the this thing. Now, this picture and this picture, I can correlate. I can use artificial intelligence later on to predict from the ultrasound what would be the grade of the tumor. And this is another third one, which is again 100% core and Gleason 3. This is the fourth one, left apex, and this was 30% core with Gleason 3. And here, the four, I did a targeted plus systemic biopsy, total 8, how many? 9 biopsy, and out of that, 4 were positive, 2 were 100%. And I found the whole tumor on the right side, but left side I had taken, and I also found the left side. So this is the third case, which was 67-year-old man, no family history, DRE PSA 10. And then he had a PRI-4 lesion of the prostate. And here I was looking for it, and the gland volume was 46 cc. But see, whole 46 cc can be seen on the picture. I can enlarge it, And then I tried to see a hypoechoic area, And this was Gleason 4/3. This is the anteriorly 4 pores, another 3, and here is 4+3, and total 3 biopsy were positive, 70, 20, 30% out of 7. So then I did a MRI. No, this is PSMA scan, and then we did a biopsy. Now here you can see the right side. Whole apical. And here, if you see the right side, whole apical was involved. See, it correlates. And then if you see the area is going up, and here it is just getting smaller. I also taken from the left side, and there you find that there is an extra capsular spread, and here I found retrospectively this is an extra capsular spread.
Yeah. Yes, sir.
Now you can see that. Now, if you see, the capsule is beautiful here, and then the moment it comes here, it is gone out. And there are some dilated ducts. And the left side was here. I had taken biopsy. The left side also we found it. And this was a extra prostatic extension. This is the capsule, and this was the extension which was found. So whatever you see on a histology, you can see on ultrasound. And then he had a radical prostatectomy. This is a 70-year-old man. He had a raised PSS in 2014, and 2 times trust-guided biopsy done. This is the number of PSA done. Twice I did a biopsy, benign. And then again he came in May, and I did. Everything was normal. There's nothing. But then he is very conscious, and did an MRI. There was a PRI-3 lesion, but nothing was seen. Then I did ultrasound, and I did not find a single lesion. And this machine also calculated prostate specific density, and it was 0.12. So, it gives you the additional information. And here is totally PRI-1 and 2 lesion, and there was no. So we are kept in on surveillance. This is the patient who's 65, who had only PSA 5.4. Bilateral little bulge, small gland, and he had MRI done, small hypointense lesion seen in the peripheral zone. He came with the MRI. So I did micro-ultrasound, and there was a small hypoechoic area, but there are few hypoechoic area. And I was trying to look for it. In the end, I found this is the one with a study, this thing, and there are very, very well seen thing. And here this biopsy was 3 plus 4, 100%. This biopsy was midland, 3 plus 4, 50%. This biopsy was Gleason 3, 100%. And then here's 6 biopsy. I mean, out of that, 4 were 100%. One was 80 and 50%. He had a biopsy. And this is another case where he had a small lesion. His PSA was first 12.4. After 2 weeks antibiotic, it come to 3.1. So I thought this is not a thing. There was a PSA 3 lesion, but he was very anxious. And we found small, I mean, MRI found a small lesion. We did a BPH and I mean, we did a transrectal sonography, micro ultrasound, and then we found some hypoechoic area. We took a biopsy. All were benign. All were benign. So in cases like this, where the PSA is not raised, but you have taken for a safety purpose because you want. And lastly, this was a 73-year-old man with a small nodule there. His PSA was 8.7. And then MRI showed a small lesion and we looked for it. This is all benign, PI-RADS 1. But here I found a small nodule. Can you see, Chandramohan? This is a small nodule. No, such a small nodule. And then I took a biopsy from there. I could took biopsy precisely from there. And
my only doubt is, have you done MRI also? And are you getting clue in these
no,
just out of curiosity?
This is my learning curve. So I must take
Yeah.
MRI. There is no question about it. And every time with MRI, like this patient, I would have done ultrasound directly. I would not have found this. And here, after MRI, I found small, but I could detect where it is.
Yeah, great. I understand.
Which is Gleason 3 and 50% biopsy there. Okay. And then second biopsy taken, Gleason 3, 50%. Only 3 biopsy I took, 2 were positive. He undergone a radical prostate. But sometimes you have an mpMRI, this is the Gleason 2. And I found it Gleason 4, small nodule. So sometimes I find micro-ultrasound gives you better. So sensitivity and specificity for organ-confined disease is 87 and 80% respectively. In summary, with growing body of evidence supporting the use of micro-ultrasound as an alternative to mpMRI has the potential to bring imaging of the prostate cancer back into the hand of the urologist. And this is the paper which is assessing the cancer risk with MRI. You have a PI-RADS with a micro ultrasound. I have a PRI-MUS. And that PRI-MUS is validated by sonographic picture, validation experiment, accuracy, consistency. And PRI-MUS protocol has made all the difference. This is a prospective validation. This was 2019. And here, whether the thing was whether you take apex or a mid part or a base, do you get the same yield? Now, we found that the apex and middle, you get more yield than the base. Because the base, you have a transitional zone, you have a peripheral zone, you have a central zone, and you have so many bladder is near, and you may have difficulty in doing it. But still, here we have found that the apical region, you have a more yield than the peripheral. So PRI-MUS were accurate across the prostate region, showing more variability from base to apex. So, and to constrain on the prostate size within 50 mm capacity of the system. So this is important. And to this is 2021. And here, if you take both the biopsy, 58% were same. 16% mpMRI showed higher grading. And 26% micro-ultrasound showed a higher grading. So this is the little difference we are comparing with the thing, because we want to make sure that we don't, we'll do the justice to the patient. So novel biopsy, what has happened because of the, if you've seen my cases where I have started doing the targeted biopsy more than the systemic biopsy. And that reduces probability and that yield is more. Addition to micro-ultrasound to our biopsy strategy leads to increased detection of the clinical significant prostate cancer without increasing the rate of insignificant prostate cancer. This is a non-inferiority study. And then micro-ultrasound was non-inferior to mpMRI and detected 97% of clinically significant cancer detected by the mpMRI targeted therapy. And clear implication here is for reducing cost and complexity of the patient care pathway. If I want to do MRI, I have to send the patient to the outside. And then there is this variability in the reporting system. And I don't understand that. Here I understand everything. And the pathway is same. He comes in the same this thing, it gets it done. And this is optimization. A novel, let me read the right. The optimum determined micro-ultrasound alone is non-inferior to MPH. It's a counterless, it is a cognitive fusion biopsy you take. And a complexity, waiting time, and cost within diagnostic pathway. It reduces variability and benefit from the imaging first diagnostic strategy. And this is what does it say? The attractive alternative to multiparametric magnetic resonance imaging targeted prostate biopsy. This is again prostate cancer detection in 2022. Now, learning curve presented here suggests expert sensitivity is achieved within first 20 to 40 cases. If you are used to ultrasound, while expert specialty generally takes 40 to 90 cases to develop if you're not used to ultrasound. So in summary, what is high resolution micro-ultrasound? High resolution micro-ultrasound enables extraordinary resolution. See the clinical important anatomical detail. Visualize the difference and anomalies of prostatic tissue. Differentiate suspicious region. Because suspicious region can be visualized, the urologist can target biopsy in the during the same routine biopsy procedure in the urology office controlled by the urologist. The future is increased early cancer detection rate and thus better imaging, better treatment plan, better patient outcome. So my aim at this moment is now I've crossed 80 and my retirement I'm going to spend on doing the field survey and utilize micro-ultrasound, see if I can detect the cancer earlier where it makes a difference.
Great.
Thank you. Thank you.
Great. Really great. Age is no bar. You can do many more, sir. There is no doubt. You can do many more. A few questions, sir, I wanted to ask.
I overshoot by 7 minutes.
Yes, no, sir. Time is not a problem here because this is see 100 people, more than 100 people have seen this rare topic. But usually by next day, 1,000 people will see. This is the usual because at leisure they can see the same thing. Sir, normally we use BK ultrasound for the biopsy, sextant biopsy or extended biopsy. And this ultrasound has both features of transrectal and transperineal. That is the advantage. Do you think that in routine cases, if you depend on MRI, for example, I wanted to have a higher mission, do you think that our accuracy, I should not ask this, our accuracy as such without this much knowledge will pick up the lesions better and it is better for the patient? And in future, do you think that this type of accurate imaging will give better idea to the surgeon? Because MRI seeing and then discussing in the office of urology with the colleagues and then planning is not easy. Even many people, I think, they will see ultrasound. MRI will tell only where the lesion is and PI-RADS. With that, we will go inside and again you have to search with ultrasound in that lesion where I have to take. And in future, targeted biopsies will have more value than just I have taken 24 or 36 like that. So do you feel that this type of progress in detecting very finer details will help us?
Answer is yes, but let me answer all your questions.
Sir.
I got B&K in 1986 because it was not a special investigation, is part of the clinical fifth dimension of clinical examination. What I palpate, I can put a probe and see. Previously, I used to
Yes.
palpate kidney, but now I can put a probe in the kidney, and then I could see that kidney has got a pyeloplastic, or a stone, or it's got a pH obstruction, or it's got a tumor. I had a pain in abdomen, and that time there was lots of pain. I did a gastroscopy and things like that. X-ray was normal, but one day I had a pain, and I did ultrasound myself, and I found a gallstone. At the time of pain, I see. So BNK is a grayscale. It tells you the gross anatomy, in not issue detail, but stone can be seen, aneurysm can be, something you can do a color Doppler, and you can do so much variability is there. But when you come to the BNK in prostate cancer, it tells you the volume. It tells you the grayscale peripheral zone BPH volume. They show the inequality of the tumor, and then you suspect, oh, it's unequal, or there is a hypoechoic area. But majority of the tumor is isoechoic. So PSA gives you idea, okay, let me do one opportunity to do a systemic biopsy was come by BNK, right? Now, this is a ultra 29 megahertz. It has a two probe. One is abdominal probe, where I can only see the kidney. And no obvious patient, I can't see the kidney. Prostate
It's like
cancer,
very focused.
it is only meant for a prostate cancer. Because prostate is small, and prostate, this is you can expand the peripheral zone up to 30 millimeters, 60 millimeters. You can see the finer detail of a tissue configuration. Now, remember, prostate cancer is number 1 in America. In the world, it is number 3 incidence-wise. But from malignancy, death point of view, is number 3 in America. In India or Asia, elsewhere, we don't have a data, but it is 5th. People are dying because of prostate cancer. Our population is aging. Previously, it was a 47 year, they were not bothered about prostate cancer. But now it has become 70, 80. I'm 80 and I'm fully, maybe I can, don't know how long I will go, but still, I don't want any cancer. So that's the advantage, because 7 megahertz and 27 megahertz, what is the difference? It is difference in prostate. Because you can bring you can bring the probe to the prostate. You do digital rectal examination, you can see the size of the prostate. You can see the symmetry of the prostate gland. You can see the firmness of the prostate gland. So this probe is just near the prostate, and you can tell you everything. Now, if you say micro-ultrasound for a kidney, I would not advise you. So now, yours is also urological hospital. So for all your organs, BNK ultrasound or Siemens or any other ultrasound is okay. We have about 14 of them. But when it comes to prostate, now this is the first machine in India. So many machines in America and Canada, and where it started and things. But now we are trying to see whether it is useful. I think what study we are doing is going to be useful to all other Indian urologists, whether they should think of looking into it.
Even is there any probe for the looking at the PCS of the kidney in this? And you say that it is not that, you cannot pick up that depth.
No. Thin patient, you can see beautiful kidney. Transplant kidney, you can see it. You can do a color Doppler. You can do the. I think in transplant, this probe would be very, very useful.
Very
because
useful.
The iliac fossa, you can put it on, and you can see it.
So, second question, sir. From beginning, when you started prostate biopsy, you start giving the anesthesia transrectally to the
local.
I mean, local anesthesia. You feel local anesthesia is useful?
Anesthesia, local injection is useful. You block the nerve. Prostatic, the nerve sparing. That nerve is where is that now? Seminal vesicle, and in the angle between there you block it. The patient feel comfortable. Even a perineal biopsy you can do under that block.
What is this company name, sir? No conflicts of interest. We should know.
Exact View.
Exact
View from Canada.
And Western population is using commonly this nowadays.
Not commonly for prostate cancer, yes. I mean, I attended one seminar from New York, you know, which was Ashutosh Tiwari. He did it. He's using it.
Okay. Okay. The
And
fourth
so many
question.
papers are there. This is the only few paper I showed, but I have gone through all the papers, and these papers are nearly 18, 20 papers are
Already
published.
published. And
And the people have done multi-centric trial, and they have, that PRI-MUS, they have done 5,000 biopsy before they came out with this classification.
Okay, sir. So now in India, if you see the PSA trend, these type of ultrasounds, do you think that between 2 and 6, when there is doubtful PSA between 2 and 6, especially in small prostates, do you think that careful analysis by inch, spending maybe some amount of time is worth, even if the MRI says perhaps 3 or 2 like that? You like to take small biopsies especially in patients who have good.
I just tell you, we did a survey. If you have history of prostate cancer, family history of prostate cancer, right? You have a PSA which was maybe say 2. 2 is in a normal. If it is less than 1, you don't need any screening. But when it comes to 2, you can, and if you don't find anything on ultrasound, or you can't pick up because it's too small, you repeat the exam after 6 months. Repeat the PSA, repeat the exam. And then you will, like me, I found that for a 3.2,
you have shown many examples.
I mean, I have seen 5, 6 example like this. So in our place, it's very easy because the prostate is small and you can screen it.
Yeah. That's what I'm.
In a large prostate, problem is if PSA is more and prostate is large, then you have a problem. And that time you must do MRI because you may not be able to pick up everything.
Sir, in extension of this recently.
So for PSA density is very important.
Yes, sir. I got the point. Small prostates, any small raise in
PSA. PSA is also important.
Sir, yes, sir. No doubt. Sir, in extension of this, recently we have seen some abscesses. Me and Dr. Soundarya also is very interested in ultrasound. We try to give antibiotics in small abscesses. And if there is no response in fever after 48 hours with higher antibiotics, we are aspirating these small pockets and they are responding very well. Do you think that in such cases also this type of intervention with this ultrasound can pick up fluid-filled lesions and so we will target properly and aspirate? Very commonly, we are seeing young patient prostatic abscesses.
Okay. So I have done 5 cases of resume.
Okay.
And I did this ultrasound, and you can see the hypo because of the fluid. You can see the changes. Now I'm because of what show.
So you can calculate the volume and changes.
You can do that. Now I have seen that that is what I'm interested is if you see a small lesion, then why operate? Why not do a nano knife? Why not do a HIFU? So here locally, HIFU is also ultrasound guided, high intensity focus.
Yes, sir. Yes.
Do the half gland, you can do it. And then you can still preserve the normal anatomy for sexual function, and you can do it. So my aim at this moment, if you detect the cancer between 50 and 60, and if it is small volume, change the technique. I mean, you don't need a radical prostatectomy. You can do the targeted therapy.
Targeted therapy. Okay, sir. Generally, in this forum, we don't mind discussing about the cost effectiveness. Most of these ultrasounds are coming up to 80 lakhs to 90 lakhs. I think that will be in the same range, or it is. I'm not asking exactly, but if you can,
It's
if you
1
can.
crore and 30 lakhs.
Okay, thank you, sir.
Okay.
With the 1
But
crore and 30 lakhs.
then if you see, I detected cancer in a patient. We are a charitable hospital. You know,
Yeah.
one person I detected, and then he's been treated. He was a already T3 disease, but treated and responded very well and things like that. And I've been monitoring. And then once he overheard me regarding the camps and thing, he said, I would like to support it. And he gave 25 lakhs rupees. I have done
Okay.
385 patients we have screened, and we have done six radical prostate. Out of that, 2 had an insurance, remaining 4 were free of charge.
Okay. Right. Great. So
Chandramohan,
it's a.
I do believe in God. You know, when you
Yeah.
are
Yeah.
intentions are good, somebody comes and helps you. So here I
Yeah.
am been able to now. Once this has been convinced, our
Yeah.
doctor will be convinced. Then you will find a way.
Yeah. What is last question, sir? What is the experience with transperineal ultra? Why you are telling anterior zone is more? I feel that a little you are talking about more focus on anterior zone today.
No.
About
Posterior zone, because it is difficult to image. Posterior zone is very well seen. You know,
very, very
but the anterior zone, you know, if you take the
small.
midline, McNeil says, if you take a midline, the entry 50% of the tumor is above.
Oh,
And that's why whenever you miss that. So to make sure that you are completely screening, you must do the anterior zone. And now it is a
anterior.
this way how you can do it.
So in
So
transperineal
when
also, do
you
you have experience? Transperineal biopsy, do you have experience with
no,
the
but
same feeling?
I have done, I mean, more than 10,000 biopsy, but I didn't have a single septicemia. I control diabetes, I control infection, I make sure that they have a ciprofloxacin, then they give enema, and then do the biopsy followed by antibiotic. And then do properly. There is the no shortcut, and then they are.
Okay, thank you very much,
Especially
sir.
diabetes to be controlled, infection,
Yeah.
you have to give some infection and give
I got the point, sir.
enema.
Now in India, it is going to be epidemic in detection of what has happened in 20 years back in USA may happen because many of the middle class people will have access to the transrectal ultrasound posted biopsy, and sudden surge and research will be there. And again, you are focusing on this will be of great value, sir. Thank you very much. Really, thank you very much.
Thank you. It was a
Thank you, sir.
pleasure.
Thank you.
Thank you for inviting me and sharing my
No,
action.
privilege.
Thank you.
It's really, ultrasound is your passion. I know, sir, very well. 14 ultrasound in one